you for this presentation that we try to discuss the management of the benign and precancerous liver disease. So we decide together to invite you because you are now you are a director of the HBP team in south of Italy. You are one of the best surgeon in Italy, but I think also in Europe, to discuss for this important issue. The Sultan Qaboos Cancer Center is a cancer center, so we discuss especially for cancer problem, but I think to know also the management of the some few lesion, I think about I'm talking about adenoma or something like that, is difficult to know how to do in this kind of lesion. So together with our colleague, we decide to invite you and to know what we need to do, what is the management of this kind of lesion. So thank you very much, Riccardo, and I leave my colleague Dr. Alfarai to say something.
Yes, thank you, Fabrizio, and thank you very much, Dr. Riccardo, for accepting our invitation and for being with us here. So it's really an honor for us. I mean, I would say for the others, Dr. Riccardo is the director of HBP unit, surgery unit in Mulien Hospital in Italy. He did his residency and fellowship in surgery in Rimondo and Paul Brousse hospitals in Paris. Then he worked as a consultant in Strasbourg before moving to Italy and becoming the director of the HBP unit in Mulien Hospital currently. He's a well-known surgical teacher and he participated in many diplomas. He's also a member of the editorial board of many journals. For example, World Journal of Gastrointestinal Surgery and the Journal of Gerontology and Geriatrics. He has many publications, a lot of publications, more than 120 articles with H index of 20. So thank you again, Dr. Riccardo, for being with us here, and I will leave the talk for you.
Thank you very much to you for the invitation. It's for me a pleasure and an honor to be here and to have this moment in which we can discuss about this kind of topic. I think it's a particular topic because we will speak about some lesions that usually are difficult to identify because they are pre-malignant lesion. I mean that it's not something that is a benign disease that could become malignant disease, but it's a category of lesion, I think, that could become malignant in case of some item that we can identify in this topic. So first of all, I am, as you told before, the chief of an HBP unit in Mulien Hospital. It's in the south of Italy. It is a wonderful place, and all you are invited to visit me for surgery and also for spend some time in this wonderful place with wonderful food that we had in our region. So if we come back to the topic, we what does it mean when we speak about precancerous lesion? Precancerous lesion is something that we identify in nodular lesion that could develop cytologically and histologically in malignant lesion. It's sometimes very difficult to have a diagnosis of this kind of problem because, as you will see later, it's really necessary to identify in the early phase of this development and this mutation in malignant, because it could be a good prognostic factor to operate this kind of lesion before they become completely malignant. We are used to manage this kind of lesion. I mean, malignant lesion is very easy now to identify the guidelines and what we should do for every stage of pathology, for example, or every kind of patient that we have with this kind of problems. I mean, for HCC, for cholangiocarcinoma, for bile duct cancer, it's just standardized the treatment, as well as we know that we have some benign lesion of the liver, like hemangioma, focal nodular hyperplasia, that has an extremely rare or impossible potentiality to become malignant. But we have some lesion that can be identified, like precancerous lesion or high risk transformation lesion, that I think they need some focus on, is because we are not able to know exactly when we can diagnose these. And we speak about dysplastic nodule in favor of HCC, cystic lesion, adenoma, on premalignant lesion that could lead and go to cholangiocarcinoma. If we speak about premalignant lesion of HCC, we identify a lot of subcategory of lesion that could be, as you see in this picture, be considered precancerous lesion. And we have dysplastic foci and the nodules can be considered premalignant lesion. And we have something like early HCC and progressed HCC. That are some different type of HCC that are that can be considered premalignant and could benefit of a treatment or a resection just when we arrive to know that they are really close to become something malignant. If we consider how hepatocarcinogenesis works, we know that most of the time we have a settle on chronic liver disease, and on this chronic liver disease and cirrhosis that lead to differentiation of the liver parenchyma in something that is more complex in structure, with the loss of function of many hepatocytes. And we know that it became a place where some dysplastic foci could grew up and became progressed HCC and early HCC, passing by the stage of dysplastic nodule. The mean and the goal of our topic is to identify when we can identify some dysplastic nodule and how we can manage them in a multidisciplinary way. First of all, it's very important, the screening of this kind of patient, because as you see in many guidelines, we can identify a population who have a high risk of develop this kind of problem. And as you can see, most of cases, patients with cirrhosis, HBV cirrhosis, viral cirrhosis, even more NASH cirrhosis, are some patients that we consider high risk and who could benefit of a strict screening to understand when this kind of evolution is starting. The most important thing is to identify, as you see in the guideline, that there are some tools to perform this kind of screening. First of all is the imaging, with the necessity of use of the abdominal ultrasound and monitoring with the alpha-fetoprotein. And in some cases, we can need, in case of doubt, the necessity to use the CT scan and MRI in order to arrive to a good diagnosis. The diagnosis of malignancy for HCC can be done at least when we have 1 centimeter nodule. So all lesions that are in with the smaller size of 1 centimeter can be considered premalignant and should be monitorized. How can we monitorize them? With CT and MRI, as we told before. In some cases, they have similar behave compared to HCC, meaning especially for this kind of perineoplastic lesion, we have a wash-in and a wash-out that can be identified in arterial phase and in portal phase. And so they have something, sometimes this behave that seems similar to HCC. And at the same time, and same thing we can identify in MRI. This is very important because you can understand the necessity and the role to discuss this kind of patient who are identified at a high risk to develop premalignant lesion in a MDT in which we have good radiologists that are able to identify this kind of lesion on this kind of images. I think it's finished the possibility that the surgeon could work on his own to identify this kind of problem. So the necessity to share and have an experience with other specialists on the subject can lead to identify this premalignant lesion. In fact, if we see the recommendation of the EAS guideline published on GI pathology, we have some non-invasive criteria, and as you can see, it's exactly only with radiological criteria that we can identify this kind of lesion, supposed to be some HCC, and we can identify this kind of lesion that could become HCC soon. So it's very important to understand that if we have this possibility, we have to discuss multidisciplinary. What will happen when we have a nodule of more than 1 centimeter? As we have read before, we need to stage them with radiological exam with CT or MRI, in which we can identify if or not they have a normal, typical behave for HCC. And in case we have not this kind of identification and this kind of behave, we could benefit of the biopsy. Biopsy still remain in some cases something very important, because as you can see, you have some characteristic that is different from HCC. And if you see the picture in the higher part on the left side, you see this plastic nodule that had been operated because of the higher doubt that it could be an HCC. In this case, as this patient was operated, it could be better, I think, if this patient was discussed before in MDT, to try to have a biopsy of the nodule in order to have more details when necessary. And as you can see the difference with an HCC nodule, you have some different spot in the presence of the vascular structure of the bile duct and on the spaces on the parenchyma of the liver. So the practice point is that we have an important role of the diagnosis to identify the early HCC, which can maybe be less aggressive than the evolution that they will have when they will be well-identified HCC. For this plastic nodule, we don't have typical vascular pattern because it's not that easy to identify this kind of characteristic with the CT scan of the MRI. It's very important to identify and to comprehend which is the size of the nodule and the kind of treatment that it could benefit. Up to now, when we have a doubt in the diagnosis, it would be interesting, even if we have doubt on the radiological diagnosis, to perform a biopsy that could give us the answer of what kind of nodule it is and if it needs a treatment or just to be monitored. So it's very important to have some MRI with specific contrast in order to have a good control of the nodule and to identify this kind of characteristic. And it's very important, and I think it will be the future of this kind of diagnosis, to develop all these tools that could help us to identify if in blood with a biobanking we can have some items that could preview the degeneration of this plastic nodule. Concerning now cholangiocarcinoma, we had some different situation because we have some tools that can allow us to identify if we have this kind of problem. Cholangiocarcinoma premalignant lesions are of two kinds and include biliary intraepithelial neoplasia and biliary intraductal papillary neoplasm that share a common carcinogenesis with the EPMN that we have in pancreatic cancer. So this is kind of premalignant lesions that are inside the bile duct, but have different radiological behave that we have to know how to manage. As you can see in this radiological image, and you see in the pathological specimen, you see always some defect in the bile tree. So it means that you have some lack in the cholangiogram, and this could be very suspicious, even if you don't have some neither a kind of mass dividing this lesion, and it's almost identified by radiologists with a sort of lack of signal in a part of the bile tree, simulating something like an inflammatory pathology of the liver. EPNB is characterized by exophytic proliferation of the biliary epithelium and the presence of fibrovascular stalk within the bile duct. So it means that you have something like some cysts, but instead they are not cysts, but they are just something like an augmented thickness of the wall of the bile duct that you add inside this kind of tissue and with this kind of dilatation. How we can see this kind of tumor and premalignant tumor, you can see, as you can see with the arrow, you have something that is, you have a lack of expression of contrast in the part of the MRI. You can understand how it could be very, very difficult to understand this kind of premalignant lesion. It seems like an isolated stop of the biliary tree, and it's very, very important that you have some radiologists that could identify this kind of lesion, because you can imagine which is the difference between this kind of patient with the liver resection, segmental liver resection in the zone when you have this kind of premalignant lesion, or otherwise you will have some extended resection with lymphadenectomy in case of development of this kind of cancer. As you can see, you have this kind of EPMN, as you see in pancreatic cancer, that maybe can have similar criteria of risk, stigmata of degeneration, like in Fukuoka criteria for the pancreas. As you see in this image, in the upper part, you have some thickness and some kind of tissue in this kind of cyst. And as you can see in the radiological specimen, in the radiological image, you have both these characteristics that are similar to the one that you find in the specimen, and it means that you have a proliferation inside the cyst, and it was precancerous lesion. What can we identify? If you can see in this study that we have in abdominal radiology 2019, you have different localization of this premalignant lesion. You have the BEN that could be localized in no matter which kind and which part of the biliary tree, as well as the TBN. What they say that there is no particular difference among this kind of premalignant lesion, because all of them have a connection with, for example, the biliary tree system, and there are no specific criteria that can allow to identify this kind of lesion. One of the most important things that they have seen, as you can see in this paper, is that we have some feature, an histological feature that can allow to identify if we have a biliary intraepithelial neoplasm, and otherwise if we have an intraductal papillary neoplasm of the bile duct. Why we can divide this kind of premalignancy? It's very important because they say that it can be considered something that we can arrive to identify with the mutation of the gene in order to understand the potential malignancy of this kind of disease. It's very important to know that, as for example, all the inflammation of the biliary tree, they can underline some pathology, it's underlying liver disease like primary sclerosing cholangitis on hepatolysis, or otherwise in intraductal papillary neoplasm, we can have some intraductal mass with some bile duct dilatation that can simulate Klatskin tumor. But this kind of images can be related with this kind of mutation of the gene, and we can have the diagnosis. I think that we can arrive to do this in future period. As always, I think that the solution will be in the molecular insight and the sign that we can identify in the kind of mutation, either for HCC and for cholangiocarcinoma, because they could lead and give us some important news about what will be the future of this kind of premalignant lesion. Why we say this? Because as you see in the evolution of this kind of premalignant lesion, just before that we see the appearance of this small nodule that give us the suspect of this degeneration in the liver, extremely early, we can identify the mutation and molecular mechanism of the malignant transformation. It means that we can identify in a perfect normal cirrhotic liver the possibility that we are arriving to have a mutation that could lead a premalignant lesion that could become a malignant lesion. So before radiology, we will have the solution analyzing the immunohistochemical marker, in analyzing the molecular mechanism just before we have the radiological aspect of the nodule and otherwise the biopsy. It's very complicated because they are demonstrating that this degeneration of this premalignant lesion is managed by estrogen, androgen, and all these subclasses are in face of some genetic alteration that lead to the possibility to have this kind of complication of the premalignant nodule, especially in patients with high risk of possibility to develop a cancer in the liver. Another part, very interesting, I think, that we can identify of premalignant lesion is a degeneration of the cystadenoma of the liver. Most of the time we face to some biliary kysts, but we know that in a part of this biliary cyst we have some cystadenoma, and especially in some cases that we will see, they can have a degeneration in cystadenocarcinoma that are considered a very rare neoplasm of the liver, but that they share some characteristic with the cystadenoma. Cystadenocarcinoma usually originate from a benign cystadenoma that undergoes to a degeneration, or otherwise we can have cystadenocarcinoma occurring almost in men, and as we see an increase in the CA99 in the cystic fluid can allow us to distinguish among the cystadenocarcinoma and the cystadenoma. So it's very, very important to have the radiological diagnosis that most of the time was made by MRI, and differentiating from the normal biliary cyst, we have the presence of multilocular mass with a well-defined capsule that sometimes seems very similar to the EPMN degeneration when we have tissue inside the EPMN. And if there is papillary projection, internal septation, wall thickness, and mural nodule, they can be identified as a risk factor of cystadenocarcinoma, degenerated on cystadenoma. You see, they arrive to develop some masses. You see masses in the liver that seems to be solid, with mixed with something like mucin inside them. So it's very, very important to treat this kind of lesion, because even if they are rare, this premalignant lesion and cystadenoma of the liver can become cystadenocarcinoma. And it's very, very particular because it could be very difficult to have differential diagnosis among biliary cystic tumor of the liver and hepatic cystic cyst. I think a good radiologist can identify some factor that can allow us to suspect that a cystadenoma of the liver can have a degeneration in a cystadenocarcinoma. Surgical treatment is possible in every kind of approach. We can have minimal invasive approach, we can have an open approach. But as you can see in this comparison among the two aspects of the same origin, meaning they can most of the time derive from degeneration of cystadenoma, you have possibility to have a different diagnosis with a good radiologist that can give you the differentiation among these two kind of problems. And it's very, very important to discuss with them to identify when or not go to surgery. Liver adenoma is the last important category. Everyone knows that we have different kind of adenomas, and it is one of the most debated subject of some lesion that could be identified to have a premalignant degeneration that could arrive to be an HCC. So it's very, very important to make a point on this kind of pathology. So we know that it's always most common in women, especially aged 35 and 40 years old. There is a potential role of sex hormones, so it's very important to understand if this increase the size, for example, of an adenoma in a woman that is assuming some hormones. we have seen that there is a recent increase in prevalence associated with the rising of obesity and metabolic syndrome, and it need to be controlled and I think treated in case they arrive to be more than 5 centimeters of diameter, because associated to the necessity to be followed closely with respect to other benign liver lesion. It's very, very important to understand that there is associated also a higher risk of hemorrhage, especially in women. We have different type of adenoma, and one of the most important risks of transformation is the presence of beta-catenin, that is represent a molecular subtype with an high association with the risk of malignancy, especially in men which are at high risk of malignancy. So how can we identify and find the correct way to follow this kind of patient? First of all, we have to identify the molecular subtype, and with an exact analysis of an MRI with a specific contrast, we can identify this patient that could have this kind of mutation. It's very, very important to manage this kind of patient in an MDT, because it's very clear in some recommendation, for example, on the fact that in men, the resection should be irrespective of size and of any characteristic, especially if we have beta-catenin mutation. We have to observe in women for more than 6 months after lifestyle change, especially when they suppress the use of hormones. And resection in women, for example, is indicated with lesion of more than 5 centimeters if they continue to grow, and otherwise they need a strict follow-up by this MDT, because it's very, very important to know that the risk of bleeding in women is very important, at the same time very, very dangerous. So what should we do? We should have this kind of algorithm that would help us managing this kind of benign and premalignant lesion, and we have to identify the category that would be a risk of degeneration in malignant. So this kind of adenoma that are premalignant. And the most important characteristic is the presence of mutation in adenoma that will be identified also with a biopsy if we don't arrive to have the diagnosis in another way, or the size of more than 5 centimeters in women, or the presence of adenoma in men. It's possible also to have multiple adenomas that always are called liver adenomatosis. And the risk, I think it's important, is the risk of bleeding and the risk of degeneration. And we have different kind of treatment, going from the embolization to the surgical resection up to the liver transplant. So we have a lot of guidelines that allow us to manage this kind of patient with this kind of benign disease that could undergo on a malignant degeneration. And the treatment should be based on gender, size, and pattern of progression, especially in patients who have multiple lesions, or especially in men or in women with beta-catenin mutation. If we consider that we can identify some premalignant lesion, as we have seen in the topic that we have just finished, we can now pass to the treatment. One, I think, of the most important and modern way of treating this kind of liver masses is the robotic surgical treatment. I think that everyone knows how the robot work, but just to have an idea, up to now we have some development in robotic surgery that allow us to be even more comfortable when we work on the side of console. This is the way in which the robot works. In this video, we have the association with this kind of positioning of the patient. So how does the robot work? We add three parts. It's very important: the vision, that we have a 3D vision, the pedal that allow to manage all the tools that we have in the robot, and the controller that allow us to operate. Which are up to now the advantages of robotic compared to laparoscopic surgery. We have two important items I think that could be stressed. The first one is the 360-degree of mobility that we have for this kind of approach compared to laparoscopic approach. And another important aspect is the fact that we have a double console allow to teach really easier compared to laparoscopic surgery. So it's very important, and I see this in my center, that it's extremely faster and more comfortable, the learning curve, if you have a double console to approach this kind of patient. Many tools have been developed, but you see in this slide, which for me are the tools that you need to have this kind of to perform some liver resection with robotic platform. Another important tool of the robotic is the simulator that allows us to improve this kind of technology, and the possibility to have some exercise in which we can train before go to surgery, for example, as you see in the short video, with nothing, and with all the exercise with increased difficulty just to arrive up to this complete ability to use the robot. I prepared some short video, and then we can discuss about the possibility of treat this kind of lesion and how can we improve. One of the most important thing, for example, in robot, is the possibility to use the this kind of integration of technology that are very, very important to go in direction of a more precise surgery. As you can see, we can use one of the technology that you have, that is ICZ guided surgery. For example, you see in this patient that had kystic degeneration.
Sorry to interrupt. I think we need to share the video.
Okay. You see now?
Yes, thank you.
Okay. So, for example, this patient had a cystadenocarcinoma of the lobe, as you can see in the upper part. And so we decide to perform a selective clamping of the pedicle and to use fluorescent guided surgery in order to have a negative margin stain in, to identify how to perform an anatomical resection of the segment 3. This is an important tool because it allows to perform something very precise as the possibility to have a correct devascularization of the liver. This other part of the video, we want to show how, if you clamp, for example, in a resection of limited segment 4, we can have a precise margin, and all this kind of stuff are very, very important to arrive to increase the possibility and reduce the risk of complication intraoperatively. As you can see here, all the vascularized part of the liver, when we put some induction in green, get colored in green, and we can identify the part of the liver with a lesion that should be resected. This is one, I think, of the most important advantages. I have a video too of the resection in young women that had an adenoma with the risk of degeneration associated to a high risk of bleeding. So I share the video. So as I told you, and I stressed before, she had a diagnosis of, as a young woman, a diagnosis of a 7-centimeter liver mass with a high suspicion of degeneration. And we had this kind of mass exactly in the middle of the liver that maybe some years ago we could treat with an approach more traditional, considering the fact that these women had a higher risk of bleeding of this adenoma, and she had pain, so we decided to treat. As you can see, we have some tools that are completely developed for the use of robot. As you can see, there are some probes that allow to have an easier identification of the anatomy with the Doppler ultrasound. You see here a sealer, that is something that we use to coagulate and to cut during this kind of resection. The principles are the same of the HBP surgery, meaning always be in safe when we perform the kind of resection, no matter of the approach that we have for the patient. So our idea is to reproduce what we perform traditionally with a minimal invasive way, using the dexterity of the robot in order to achieve a satisfying result. You see, compared to minimally invasive surgery of the river or laparoscopic resection, we did not have the CUSA, that is the ultrasonic dissector that was very useful in this kind of dissection. But as we have learned from the master, as Fabrizio and some other, we can perform this kind of resection also using the cheliclasia, the classic cheliclasia that we have used in open surgery many years ago. It's very important to interface with tools that we have available to arrive to find the correct plane to resect this kind of lesion. So we identified the higher part of the lesion, as you can see here, of the adenoma. We know that it was not a premalignant lesion, but it was necessary to resect in order of the risk of bleeding of this adenoma. So we proceed to an enucleation in the middle of the liver in order to reduce the risk of bleeding for these young women. We use always the identification and the section of the pedicle after have clamped them and after have verified, for example, as in these cases of the segment 4B, the pedicle, we want to be truly safe when we perform this kind of resection. As you can see, everything is performed when you arrive to be exactly safe and sure of what you are doing. You see, we continue the dissection. It's very, very fragile, the adenoma, but we arrive with some small movement, fine movement that can be reproduced with the robot. We arrive to completely dissect this kind of lesion. Technology, I think, should be respected and should be used in correct indication in order to benefit really of this kind of technology and to find the right place for this kind of lesion. As you can see, the resection goes on. We identify all the small structure that we have in the liver, and we arrive to dissect the pedicle also without the use of ultrasonic device. All the structure, as you can see, are magnified, and it's very, very easy to dissect them and to respect them, as you see in this part of the video in which we move close to the hilar plate using the bipolar tool of the robot, respecting the hilar plate, the left pedicle, the right pedicle with the bile duct. Resection continue. We arrive to lift up. You see behind the sucker, we have this adenoma that is just lifting up, and we move a little bit, rotating and creating a sort of the cave in the middle of the liver. And then we have the vena cava on the bottom part of the liver, and in the higher part you see the right hepatic vein that is growing up. In the left part, in the right part of the screen, we have the left pedicle, and in this way we arrive to complete mobilize all the mass, respecting, as you can see, the middle hepatic vein in the upper part, the right hepatic vein in the lower part, and at the end we arrive to remove completely all the adenoma. And as you can see, we had this wonderful image with the middle hepatic vein on the top, the right hepatic vein on the bottom with the vena cava, and the pedicle, left pedicle and the right pedicle. So we can achieve this kind of resection, even if we don't have all the tools that we have in laparoscopy, but it means that it's possible, feasible and safe to perform this kind of resection also for premalignant lesion. So in conclusion, I would like to stress some concept. I think that first of all, as you have shown in your previous conferences, it's very, very important that in a center like the cancer center, all decisions should be identified and performed multidisciplinary, because it's with the collaboration with colleagues that we can identify the correct pathway, the correct treatment for patients who are at risk that some premalignant lesion could become malignant lesion. And the second thing is that I want to stress is that technology as robotic are very, very important, because they allow us to improve and to give some treatment for patients that I think that could not be performed in laparoscopy and need to be performed in open surgery. So robotic, I think, is an extra value for complex treatment that we used to perform in open surgery that now we can move to minimal invasive surgery. Thank you very much.
Thank you. Thank you. Could you hear me or not?
Yes, yes.
Yes, I have two comments. I don't know if Dr. Adil from the University Hospital, Dr. Al-Warit from the Royal Hospital. I have two comments. I don't know the incidence of this kind of lesion in Oman, but in Gulf area. And I know that in Oman you don't have the robot. So the role of the laparoscopic surgery, laparoscopic approach on this kind of lesion, because as we can see very well from Ricardo, with the robotic approach, we have more resection, I think, because we could dissect very well the vessel. I don't know if we could do the same, we could perform the same in a laparoscopic approach. So I would like to ask to Dr. Adil and Al-Warit if they have a comment.
Prof. Panaro.
Yes.
Yeah, thank you for the lecture. It was excellent lecture. Actually, with our population, Prof. Panaro, we had very little of benign liver lesions like adenomas. And there were few female patients with adenomas. We had to do some biopsies to confirm they are inflammatory types. And we decided to watch them. I personally have not operated on any adenomas. There was one lady recently we decided to operate, but then she decided to take a medical report. She disappeared. And she had multiple adenomas, and one of them increased in size over the 3 to 6 months period.
Okay, thank you very much, Adil. I don't know if Al-Warit is another hepatobiliary pancreatic surgeon from the Royal Hospital. I don't know if still connected.
Hi, Ricardo. Hi, Fabrizio.
Hi.
Thank you, Ricardo, for this presentation. I do remember you from Strasbourg, actually, when you gave us the robotic surgery course with Patrick and the team.
Exactly.
So nice to see you again, Ricardo. I'm so happy that you are in Italy and in a very nice center there. Well, in Oman, since I joined, actually, we do have few cases of adenoma, and in some women, they are really related to the OCP. But as Dr. Adil said, few cases which are large, actually above 5 centimeters. And we do have 2 cases, actually, patients who has got multiple adenomas. And unfortunately, they present it actually with the HCC already. And I remember when 2 months back we operated in rupture HCC, rupture adenoma, and it turns to be the histopathology report as poorly differentiated SCC, because adenoma actually, if degenerate, usually degenerate in aggressive form of HCC. But as Dr. Adil said, I mean, from our population, we don't have a lot of cases, but most of the cases are below 5 centimeters. We usually watch watch them every 6 months, and if they are above 5 centimeters, we operate directly. We don't do, actually what we did is all open surgery. We don't have the robot here. We are trying to get it. Hopefully Da Vinci will be so kind with us we don't have issue with money, but the issue is sort of administrative issues. Maybe Professor Penaro knows that, and hopefully we'll get it soon because it will help us a lot.
Thank you, Dr. Ricardo, and thank you for the others. It was a nice presentation with nice videos, honestly. I will keep maybe the place for the others if they have any questions. Just for the time being, Dr. Ricardo, we say always that, I mean, the adenomas with the beta-catenin mutation, we need to operate on them, which means biopsy. I mean, do we need to biopsy every adenomas?
No, it's possible, as I show you, because it's very, very clear. I find them on the health guideline that it's possible to identify population at risk of this degeneration, because it's very, very important to identify the molecular subtype associated. So the one with the mutation are in order to be identified. And if we add some extremely expert radiologists, we can have almost the certitude of the characteristic watching the MRI. Sometimes they have some aspect that is extremely characteristic, and sometimes they need biopsy, sure.
Okay.
I don't know a question. I don't know if Professor Mansour is connected or not. I don't know if in the project of the Sultan Qaboos Cancer Center is one of the biggest now in the Gulf area. If we have in Oman screening program for this kind of lesion, I think for hepatic lesion. I know, for example, in France, there is a screening program with the ultrasound and an alpha fetoprotein to detect very early ACC. I know that in Oman we have for the breast, maybe for the colon. I don't know if in this cancer center would you like to create a sort of screening program for hepatic and hepatobiliary lesion.
Thanks, Fabrizio. I am connected. I have been listening, and I would like to thank Ricardo for an amazing presentation. As far as screening for the center, we believe this is more of Ministry of Health program, because it requires an infrastructure which is countrywide, and I don't think we will be able to do that from the center. Do you hear me? Dr. Abdullah, do you hear me?
Yes, Prof. Mansour.
Yeah, so I think it requires a national infrastructure. In fact, we don't have, even for breast cancer or colon cancer, any screening program in the country. In breast cancer, I did not see the study, but apparently there was a cost-effectiveness study, and it was negative. This was many years ago. On a smaller scale, there are some mammographic studies which are held in hospitals after patient present. But a national program which is well established for breast cancer and colon cancer, until now we don't have. We intend in the center to participate in drawing the strategies for national screening programs. But to undertake such venture, it might be challenging for us for the main reason that we require a countrywide infrastructure to do that successfully.
Yes, yes. Maybe the future of the cancer center maybe a good idea to create a sort of system of screening for to detect maybe hepatic lesion or cancer, early cancer. Maybe
Yeah,
yes.
In-house will provide the service required, but will be based on patient presentation more than a national program. But I think maybe my colleagues can comment on that. Patients who have cirrhosis undergo careful screening with ultrasound. I don't know whether there is a crossover between this category of patients that have cirrhosis and adenomas or macronodular lesions that are difficult to differentiate from HCC. Yes, thank you.
Thank you. I think there's a question.
Hey, Ricardo said now from France, Montpellier. I am with Panaro.
Yeah.
I joined the lectures and the last party. I saw the film. It's very, very interesting. I saw that you utilize always the cheliclasi pour les parenchyméctomies. It's interesting, but you don't need a good assistant. What about the lesions in the cirrhotic liver for doing the parenchyméctomy? Have you ever? What is your experience for the other types of parenchyméctomy, like CUSA, for example? What's your comment about that?
So I've thank you for the question. I have we have tried. I have an experience of some cases in which we perform, for example, right hepatectomy. So with a straight line of transection, in which I think we can benefit of the use of CUSA from the assistant while you perform cheliclesia with robot. So you have your assistant that is which is close to the patient that can use CUSA, but I think it's very useful if you have straight line of parenchymotomy, like left lateral sectionectomy, right hepatectomy, left hepatectomy. It's quite a little bit more difficult when you have something like segment 7, segment 8, or posterior superior segment, in which the axis of the port of the assistant is not the axis of the resection. For this reason, we have used we have developed the possibility to use the double cheliclesia, meaning left end and right end, both them connected with bipolar, so it's easy to have the coagulation of both the side. And the other thing that helped us when we have difficult parenchyma, like you told, cirrhotic liver, we used to completely mobilize the liver in order to have segment 6 and segment 7 in the position of segment 5 and segment 8, in order that you can use CUSA too.
Okay, thank you very much.
You're welcome.
Thank you. There's a question, I think, by Dr. Yusra.
Yes, sir. Good evening to everyone. Is it okay, sir? So I don't know whether.
Yeah.
Hello, good evening to everyone. Yeah, yes, sir. I'm a medical officer, actually surgical medical officer. I have a question, sir, regarding the adenoma, what you have mentioned in your slide, one of your slides, that regarding the adenoma, any size of the tumor, especially in male, should be resected. So is there any particular reason that, so if you can mention, especially in female, you have mentioned that it is connected to most of the time it is due to OCP. But in male, irrespective of the tumor size, it should be resected, like that it was mentioned. So can you just mention what is the reason, what is the reason behind it?
Yes, the reason is that it has seen that it's a typical pathology of the women, and if present in male patient, it has been shown that in male, due to some molecular and hormonal stimulation of the adenoma, we have an increased risk of degeneration of HCC, irrespectively of the size and of the age of the patient, and if or not it is single or multiple adenoma. So in men, it has been that you have an extremely high risk of this benign lesion became a malignant lesion, and so it's easier and maybe more prudent to treat them when they are identified in men, and the size is small.
Yeah, just can I add something, Ricardo?
Sure.
Yeah, yeah. There is a nice study actually in which has changed the management of adenoma from Olivier Farad from Paris. This is the study actually which shows there is a high risk of malignancy in men. It's good, Yusra, that you go back and to this study. It was published, I think, in 2010 in Annals of Surgery, done by Olivier Farag in Paris. It was, as Ricardo said, there is a very high risk of malignancy, irrespective of size in men.
Okay, thank you very much. Thank you
very much.
Thank you.
Thank you. Just Dr. Ricardo, another question regarding the IBMB, the one who were resected. I mean, what sort of follow-up do we need for them? We know, for example, for the IBM and for the pancreas, we need to follow them, I mean, long-term wise, but I don't know for the liver.
So it's not extremely clear in literature, or there is no guideline. I searched if there are these kind of possibility to have a follow-up, because as for example in pancreatic EPM, we have some stigma of malignancy. I've seen that when we identify in liver this kind of stigmata, meaning like wall thickness or presence of vegetation inside the kyst of septa or something like that, it is more often treated surgically because of the high suspicion of the possibility that they have cancer inside. If we start, I have had one cases that I had in follow-up for 2 years, because he had something very peripheral in the liver. In segment 7, he had isolated dilatation of a small duct, and I have a follow-up of this for about 2 years with an cholangio MRI and MRI with hepatospecific in every 6 months. But we decided to operate him when he had an increased value of tumor markers, and then we find that there was small cholangiocarcinoma. So it's very, very important to have follow-up. But if you are in front of something that seems to be extremely clear as to be something abnormal in the liver, on the biliary tree, I think they should treat as soon as possible.
Thank you.
Okay,
thank you, Ricardo, for this wonderful lecture. Thank you, Abdullah. It was very, very well organized. It's interesting. It's a very high specialized field. So I know that in Oman there are few cases, but I think it's difficult to manage if you have a few cases. This is the main problem. So why we decide together with my colleague Al-Farai to discuss together, to discuss today this kind of management. Do you have, I don't know, other question? I think we must finish because we are 6 p.m. Do you have other comment, Abdullah or not?
Yes, as you said, Fabrizio, yeah, it's already a rare entity, and we have a small population. So you could imagine how few numbers we have of this pathology. So would like to thank you again, Dr. Ricardo, for being here with us. It was
thank you. It's been a pleasure.
Thank you very much, and thank you, Fabrizio, for your support.
Thank you. I would like to introduce the next HBP Coffee, because with Abdullah we decide the next issue. So we invite a German surgeon, but now we can't say the name because it's a surprise. We will discuss about the indication on liver transplantation for colorectal metastasis. I think it's a good issue for the Oman, because as we know, we have a lot of cases of colon cancer, and especially in young patients. So I think it's a good issue to discuss. And thank you, Professor Mansour. There.
Thank you very much.
Thank you very much. Thank you.
Thank you very much.
By the way,
Thank you. Bye.
it's almost the time for the
Bye-bye.
Omani football match team today.
Yes. Bye. Thank you.
Bye-bye.
Thank you very much. Thank you.
Thank you.